Respect to the deteriorating patient. Hi, I'm Abigail Short, and I am an intensive care and anaesthetic consultant in NHS Forth Valley. I made this video with Dr. Lindsay Fielding, a specialist in ageing and health also in NHS Forth Valley. I'm going to talk a bit more about how to identify, assess and manage a deteriorating patient and the important role of emergency and anticipatory care planning. There are many different ways that we can expect to encounter patients who are deteriorating or are at risk of deteriorating. Sometimes a health crisis occurs when there is a sudden, unexpected event, like a stroke or a heart attack. But more often, these deteriorations can be anticipated in those who have an underlying chronic or life-limiting disease. Indeed, many who end up admitted to hospital are already on a deteriorating trajectory, with advanced states of frailty, cancer, or organ failure. Anticipating and planning for deterioration helps us create the conditions for the safe delivery of care for every person within every setting, every time. All patients can benefit from this. However, tools such as SPICT can help prioritise timely care planning by helping to identify those entering supportive or palliative phases of illness. Understanding the context of a deterioration is essential whilst assessing a patient, particularly where they may be too unwell to have discussions about their care and treatment. This not only helps identify the cause of the deterioration, but also helps us to understand the person's previously expressed wishes about care and supports discussions about treatments that may or may not help. For example, in a hospital setting, we might review a variety of documentation, including key information summaries and respect forms. So how do we identify if someone is deteriorating? There are different ways in which we can do this. The National Early Warning Score, or NEWS2, is widely used in hospital settings to identify a change in condition, but there are potential pitfalls in relying solely on this. Some people, particularly older patients, may not have a significantly raised NEWS2, but may have other signs such as falls or a change in function as a marker of deteriorating health. We can also use baseline clinical frailty scales to objectively gauge a change compared to a previous level of function and level of frailty. Most importantly, a careful history and collateral information from the next of kin or primary caregiver is a part of a comprehensive frailty assessment. Common causes of deterioration include sepsis, and prompt identification and management of sepsis is vital to improve patient outcomes, where escalation of care and life-prolonging measures are the agreed focus of treatment. Acute kidney injury is another common cause, and particularly common in older patients. A detailed review of medication is a key part of the assessment and needs to be regularly reviewed as the situation changes. Delirium, which accounts for significant morbidity and mortality and predominantly affects older people and those with underlying cognitive and sensory impairment. The use of 4AT delirium screening and information from family members and carers can help readily identify this. Falls may be the cause or a sign of clinical deterioration. Identifying if there is a falls risk, how can I reduce this and any significant injury? Timely assessment and response, once we have identified a deteriorating patient, is of course vital to improving outcomes. Consider, how quickly are they deteriorating? Are they at risk of cardiac arrest? What is the plan if this patient gets worse? Do they have a treatment or escalation plan? For example, a respect document. Should we initiate a respect document? Do I need to ask for help? How am I going to make sure this patient is cared for when I am not in the clinical area? Safe and effective team handovers are paramount, and an SBAR format is often a useful template. It is important to agree realistic treatment options with your patient, which will be based on their previous and existing health and underlying conditions. We often try to establish what someone is normally like on a good day, and ask questions like, how far can you walk? When did you last do this? When did you last feel well? What has changed recently? Involving others in discussions about a person's treatment and care is important, and it can help clarify the person's usual health and functional and cognitive well-being. Is the patient currently well enough to be able to be involved in decisions about their care? The ability to engage in discussions will be specific to the decisions being made. Capacity should be optimized where possible and may fluctuate or be a temporary state. What are the priorities for treatment in care? Have the risks and benefits been explained? Are the expectations for care realistic in the context of their current illness and previous health? For all patients, it is important to individualize our approach to their management. Much of what we can do without a filter can cause harm. Think about safe medicine reconciliation. Are there medicines that are non-essential or harmful just now? Assess VTE risk. Do they require low molecular weight heparin? Do they need a dose adjustment? Fluids and nutrition. If supplemental fluids are required, what type of fluid does this person require? Consider the person's nutritional state and how this could be supported. News 2 and 4AT tools can pick up deterioration in a hospital setting. This leads on to the consideration of where best to care for this patient. In a hospital setting, there are 3 levels of care. Level 1 care is also known as best ward level care. The majority of patients admitted to hospital will be managed in a normal ward setting or level 1, where treatment can be administered such as IV fluids, antibiotics or oxygen. This may be the maximal level of care that is desired by the patient or appropriate for their level of overall function and health. Planning for whether higher levels of care should be considered is important and should be communicated if there is evidence of current or future deterioration of health. Even where HDU or ICU care is not appropriate, this doesn't mean no treatment. Level 2 care is also known as high dependency care, and this is where single organ support is offered, most commonly in a non-invasive fashion, and has a higher ratio of nursing to patient care. This level of care doesn't automatically mean escalation to level 3 will happen. Level 3 care is the intensive care unit. In intensive care, machines can support the body and aim to replicate the normal organ function, giving time for either treatments to work or the body to overcome and recover from the underlying illness. Level 3 intensive care will not be of benefit for many patients, and many do not wish this level of intervention. Invasive organ support comes with challenges and potential complications for the patient and their family, and often a long recovery time. The ICU mortality rate is around 20 to 30%. Survival from ICU does not guarantee survival to hospital discharge, with an extra 10% dying before they are able to leave the hospital. We need to be open and honest in our communication about what we can do and what will not work or may leave the person in much poorer health if they do survive. Communication needs to be sensitive, timely, and tailored in a way that is easy to understand for each individual. Sadly, even with our best efforts, people still die. Identifying the dying process is important as it allows us to focus on care and treatments that will alleviate discomfort and distress, as well as preparing the patient and family for what lies ahead. This opens up discussions about the best place of care to support their care needs. Further information can be found on NHS Inform and Good Life, Good Death, Good Grief website. At all levels of care, we must ensure good symptom control, rationalise medication, and focus on treatments that help. When approaching conversations around CPR, it can be difficult to know where to start. CPR should always be discussed as part of an overall treatment plan and not in isolation, as this is often associated with negative connotations. Survival from cardiac arrest depends on a number of factors, including where this occurs and the likely underlying cause. Around 1 in 10 people will survive to hospital discharge with an out-of-hospital cardiac arrest. With an arrest that occurs in the hospital setting, more will survive, but these are of those deemed appropriate for CPR. CPR does not usually work in advanced frailty. Most people with a cardiac arrest have a non-shockable rhythm such as PEA or asystole, and these have poorer survival rates. These rhythms are more likely with advanced lung, heart, kidney, or liver disease. Survival is higher for those with shockable rhythms, for example, ventricular tachycardia or fibrillation. Even where people survive, CPR can still cause harm, such as fractures, so this may need to be considered in conversations if appropriate. Any lack of oxygen during CPR will worsen cognitive function, particularly in those with existing brain impairment. Following a resuscitation attempt, people will potentially be in poorer health than before, and if someone has advanced stages of cancer, organ failure, or frailty, or they are approaching the end of life, then CPR will not work. Treatments that won't work should not be offered as a treatment option, but sensitively discussed with a focus on what we can do. For more information, visit NHS Inform. Care planning conversations and decisions can be recorded in the clinical record using specific documentation, for example, respect forms, and increasingly will become electronic or digital. This is important as it provides a record of discussions if the patient is too unwell to be involved in decisions about their care at a later time. These should be updated with changes in a patient's wishes or condition. Conversations about care and treatment planning are not always easy, and it can be difficult to know where to start. Tools such as RedMap can be a useful framework to keep you on track. A shared decision-making approach should be adopted where recommendations are a balance between realistic treatment options and patient wishes. Individualized communication tailored to the person's needs is required when considering specific treatments, and the Choosing Wisely brand question tool is an option when weighing benefits, risks, alternatives, or changing nothing. It is important to explore what matters to the person now and in the future. And it is important to have a structure for these difficult conversations. Opening the doorway for shared decision-making and ensuring patients and families are at the centre of their care planning is better for everyone and improves patient safety and care. For more information on this, please visit our internet and intranet pages in NHS Forth Valley. Follow us on Twitter at RespectFV or visit www.resus.org.uk/respect and NHS Inform. Thank you to all those who contributed to this video and Macmillan Cancer Support for supporting this work.